Thank you very much. I was able to understand one word, philos, which means friend of Greece. And it is very true. I have good friends, George, Dimitri, many other in Greece, and I was happy to accept this kind of invitation, although I'm a little sick, but I hope you accept this low voice. A few words about the city where I'm coming from. It contains a lot of neoclassic style, looking like a little piece of Greece. This is the old cloister of the hospital, which is 1,000 years old. And today the hospital has a large department of nephrology, dialysis, and transplantation, where we have a lot of sub-departments inside, including extracorporeal therapies for critically ill patients. In 2000, we started the restructuring, and then we ended up with this. This is our department on the 3 floors, our dialysis unit. We have an operating theater for fistulas and catheters, and the so-called Vicenza model includes the utilization of all intensive care techniques in our department to collaborate with our critical care group. Recently, we founded the International Renal Research Institute, and we placed this on the 3rd floor of our department. It has been completely paid by charity and friends and donations. The hospital didn't spend a penny, and this is how the institute looks like today with the entrance. And as you see, a little piece of art is also on the walls. We have new labs, and we use the term green to define our mission, which is genetics, robotics, informatics, and nanosciences. And in all these departments, we do actually activities related to diagnosis, epidemiology, genetics, bioengineering, new machines, and toxicology. One of the ideas has always been to bridge towards other disciplines, but not just medicine, healthcare economics, health technology assessment, bioengineering, mathematics. And we have a museum inside the department to remember that we are coming from an evolution of this machine, and especially for young fellows, it's important to know that the new machines today are coming from a lot of study and a lot of effort, and everything is described in the museum. And this is our meeting room there, and these are several of our fellows that come from all over the world, as you can see here, including Greece, of course. And they have a special place on the wall of our institute. Dimitri is here as well, so it's a pleasure, and it is a pleasure to work with them. Now, why did I show you this? Because in the last 30 years, the evolution of critical care nephrology and machines for renal support has been always led by the Vicenza group in the sense of designing new machine or testing new machine or developing the ideas. In 1977, we started basically with peritoneal dialysis, and there was a need for an alternative because of unstable patients. So that started the era of CAVH. CAVH was initially performed with a highly permeable filter with an artery and a vein, puncturing the artery and the vein with substitution fluid and heparin in this place. And this was the original circuit. So it was done with modified hemodialysis bloodlines. This was an idea that was originally also for chronic patients, but then, of course, chronic patients had to move to intermittent treatments to go out of the hospital. While Belden Scribner came to us in Chicago and said, we always wanted to do this, and now finally you can do it, and that's a great thing. So we studied the dynamics of continuous arteriovenous hemofiltration, which was basically a circuit pumped by the heart, moving blood from the artery to the vein through a highly permeable circuit. Look at the size of the catheter we had to use in order to get enough flow of that time. This was a typical vascular access, but also we needed to have short lines in order to have less resistance in the circuit. And the negative pressure generated by the height of the column putting the collector on the floor was producing ultrafiltration in the system. Hemofilters originally were too big, and therefore they were actually having a last part of the filter not working properly with hemoconcentrated blood. So the idea was to design new filters or to change the structure of the fiber or to optimize blood flow. First of all, we designed new filters, as you can see here, much smaller compared to the original one. Then we discovered that with smaller filter, the resistance was much more lower, and therefore for a given arteriovenous pressure gradient, the blood flow through the circuit was much higher. And in fact, you see, when you have an unstable patient and you are having pressures in this area, the blood flow was close to 100, while with the other was much, much lower. So we designed an entire structure of filters, and today, together with the flat, they are in our museum because they have been developed over the years. Then we moved to a further evolution. The idea was to optimize fluid balance. That was one of the first computerized control ultrafiltration system. And then we designed, this was a gravimetric control system with a control panel here, or two pumps with a special scale here. Simultaneously, in the United States and Vicenza, we developed the countercurrent flow configuration. In the United States, they call continuous dialysis. In Vicenza, continuous arteriovenous hemodiafiltration. That was the first description of hemodiafiltration. The reason why we had to work on this was that the original filter only had one port. So we had to design filters with two ports in order to circulate dialysate. And this was the first patient who had a countercurrent dialysate flow rate in the system. Also, we moved to veno-venous pumped circulation. Today, it seems very logical, but at that time to put a blood pump in an ICU was a complicated issue. So thanks to double lumen venous catheters, we could actually have a veno-venous circulation, and we started to use machines. Part of this were borrowed from the technology of the chronic dialysis patient, but definitely we could increase blood flow, and so we could increase ultrafiltration, and so we could increase surface area of the dialysis. We designed machine and pumps specifically for continuous veno-venous hemofiltration, and this, for example, was characterized by a specific filter pressure drop monitoring that was telling us when the filter was almost clotting. But we ended up with the Christmas tree syndrome because we wanted to add heparin, ultrafiltration control, warmer, manometers, infusions. So very often at the bedside of the patient, we ended up with the Christmas tree like this. And the problem was that these machines were not talking to each other. So what we wanted to do was to move to CRT machines specifically designed. And as you can see here I'm going to show you a series of machines like this or like this, all characterized by a blood pump and dialysate in, dialysate out, or ultrafiltration and reinfusion. Again, this is a similar concept. And this machine was designed in Vicenza, and it is actually the grandfather of this machine that subsequently evolved into this machine. So modern machines today have quite large screen and the capacity to perform different kind of therapy. The important thing is also they can manage a large amount of fluids, and they have a warmer for the dialysis fluid. The first step forward was really made by the Prisma because it was specifically designed. We nephrologists say it was so easy that even an intensivist could use. But basically, the self-priming was particularly important to perform this therapy. And this was a pre-prepared circuit that was available in this machine. Then other machines, for example, had specific guidelines in the screen so that the nurses could follow step by step what to do. This is another machine, and you see the number of pumps is increasing because of the different options in terms of therapy. And then the third generation of machines came with specific features, higher blood flows, gravimetric control of ultrafiltration, built-in printers, possibility to include devices for blood volume measurement. You are familiar with this machine with large screen, for example. In the United States and Germany, they have used machine derived from the chronic market, the Genius and the SLED, but they also have produced this multifiltrate with the characteristics of having different pages in the large screen that allow you to perform easy therapies. Then another step was to move from the original Prisma to the Prisma Flex. You see different color compared to what you're used today. These machines, first of all, had 5 pumps. Second, they were mature to develop citrate anticoagulation and other technologies. There are other machines, these are from the United States, with a specific cartridge completely pre-mounted on the machine. But the evolution of extracorporeal organ support has moved towards the concept that the machine is, rather than a renal machine, is more a platform for multiple organ support. So we know already that we can support the kidney, and as you know, patients, when they are very sick, they tend to die. When they are not sick, they tend to survive. But in between, the large number of people may benefit from higher dose, and we published this paper in the 2000 in Lancet where we showed that the use of higher doses actually may provide better survival. In particular, we found also that if you are a septic patient, you may benefit from higher doses. Other studies have shown that daily dialysis may be beneficial compared to alternate dialysis. Soudan and others have shown that if you increase the dose, you can get a better survival again. So until a certain point, there was a concept that more dialysis was better. But of course, you cannot provide immortality. So other studies have shown that if you increase beyond a certain point dose, you do not have a beneficial effect. And there are 2 major trials. One is the veteran administration called ATN trial, and the other is the renal trial that show no difference when you reach a certain amount. However, you must know that very often we do not deliver what we prescribe. So because the patient has to stop, has to go to the radiology department and so on. So we prescribe much less. And in a study that we did, we found that although we prescribed 34 milliliters per kilogram per hour, the median delivery was 27. So very low, and we recommend to not under-dialyze the patient. Basically, for the kidney, we can say there is a dose-survival relationship until a breaking point, and then here you have a plateau that depends on practice. In summary, we can say that recent trials have failed to confirm earlier trials. However, they have confirmed that CRRT is the standard of care. They have confirmed that you have to reach at least a certain dose, so the idea of prescribing 30 to 35 milliliters per kilogram per hour is reasonable making sure you do not deliver less than 25, and the improved survival show the importance of using continuous therapies. But we can also support the heart. Heart is supported today by simple ultrafiltration techniques, and I will present in the second talk the concept of the 5B, which is basically balance, biomarkers, BIVA, blood pressure and blood volume, and I will present in a minute. The machines today available for ultrafiltration, they allow also to do ultrafiltration with peripheral blood access. And this was a study performed by Maria Rosa Costanzo showing that patients in the ultrafiltration arm compared to standard of care, they had less rehospitalization and they had a better outcome compared to patients treated with diuretics. A little look at the future, we also have tried to make ultrafiltration from inside the body. We have placed fibers on top of a catheter to try to make intracorporeal ultrafiltration, and we are studying wearable ultrafiltration techniques. This was the first prototype, and today we are working at a specific device that actually allow to make together pumps and filters. This is the filter that we studied recently, and this is the device that we are trying to study for ultrafiltration. We can provide support to the lungs because with a small oxygenator, we do not do ECMO, but we do decapnization. We remove CO2 from the patient thanks to a dry-wet interface in the oxygen. So this is the circuit. And we have the oxygenator here, we have the filter here, and you can use this both as a separate unit or in conjunction with the CRRT technique. You can, in fact, combine the decapnization with the renal replacement therapy. As you can see here, the two filters are actually combined. What do we achieve with this? We can keep tidal volumes so low that we can achieve what is called ultra-protective mechanical ventilation. You know that normally we recommend values below 6, and now we can actually lower the volume. And in some cases, we can even move the patient from this condition to this condition, extubating and not continuing mechanical ventilation. We can support the liver. The Mars system, which is an albumin circuit, or the Prometheus system, when you have a membrane permeable to albumin and the sorbent that is circulated in the system. And we can support sepsis. Sepsis has been treated with extracorporeal therapies with the concept that mediator clearance can be achieved, either with higher volumes, either with higher membrane cutoff or with the use of sorbents. Higher volumes are complicated to do 24 hours. So what we do is a pulse high volume, which is for a few hours in the day, we do 6 liters per hour, and then we continue with the standard 2 liters per hour. But the results we found was that there is a definite improvement in apoptosis and the phagocytosis capacity of monocytes of the septic patient. The efficacy of large cutoff membranes have been studied in animals with models of sepsis, and also with the possibility to remove, for example, myoglobin in case of severe rhabdomyolysis, but also the possibility to significantly reduce circulating levels of plasma cytokines. So high cutoff membranes are actually expected to remove myoglobin and also cytokines. Removing these substances probably will change the hemodynamic condition of this patient. We also use sorbents to combine with hemodialysis, as you can see here, or we use coupled plasma filtration adsorption, where we filter the plasma we circulate through a sorbent, and then we reconstitute the blood and dialyze. This is the device that have been experimentally used, and what we found was not only a dramatic reduction in the requirement of norepinephrine, but also an increased production of TNF and increased phagocytosis from monocytes that were originally paralyzed. So the response of the patient, the immunoresponse of the patient, is improved. And today there is a cartridge that is prepared for this treatment, and there is also a new machine that allows to perform this therapy completely. Endotoxin removal has been an interesting strategy due to polymyxin B immobilized on polystyrenic fibers, and we did a study on relative risk for death after treatment with this technique, and we found actually a significant reduction in the relative risk for mortality. In a study we published in JAMA, we found also at 72 hours significant decrease in SOFA score and a difference in 28 days survival. Bioartificial solutions combining cells and scaffolds of plastics have been used, and they are still under evaluation. The final evolution has been for pediatrics. For many years, we did treatments in neonates with specific filters. This was the first neonate treated in Vicenza with a mini filter that we designed many years ago. And we have treated several patients, and these mini filters are now used all over the world. But today, arteriovenous infiltration is not used anymore, so the machines are the classic machine for adults. But unfortunately, they are off-label for these neonates. So what we tried to design machines that could actually match the size of the neonates. And in fact, these are drawings that I did myself, starting to see how I could improve these machines for neonates. And these are a little more professional drawings. These are our first prototypes. Just to show you, this is the pencil, so this, you understand the level of miniaturization. Then we came through a collection of charity donations to a project with the design of a new machine. And we call it the Cardiorenal Pediatric Dialysis Emergency Machine, Carpe Diem, and we developed the machine. And this is actually the president of our association, so this was completely developed in our center with no money from government, from the hospital, from companies, from anywhere. This machine has a priming volume of 15 milliliters. So it's a very, very small priming volume. It's full of technology inside, but the characteristic is everything is miniaturized. You see the blood pump and the ultrafiltrate pump are very, very small. And it is very easy to manage because it has only one button, and this is the very simple screen of the machine. Today, this is the machine available. We found a company that wanted to develop this machine finally and make it commercially available. And this is the first baby treated in the world with this new machine. So to conclude, I would say that mortality tends to increase when you have an increase in the number of organs involved, and you need actually to see that to treat the complexity of the syndrome, you may actually need to have more complex technologies. And you're all invited to come to our Vicenza course on critical care nephrology that starts in June 11. And with this, I thank you for your attention, and I may go to the second presentation, or we can discuss this as you prefer.